All right, I think it's 8 a.m., so we can go ahead and get started. Hi, everyone. My name is Ryan. I'm an emergency critical care doctor out in New Haven at Yale. And when we started thinking about this talk, it developed from the concept that amongst developing ECPR programs across the country, when we started talking to each other about what we were encountering in terms of Am I not loud enough? Can you guys hear me like this? That's Andrew, can you hear me? You're good? Okay. I was going to say, I've never once in my entire life been told you need to talk louder. So what we found was everyone was experiencing kind of similar considerations when it came to ECPR implementation. And I found myself constantly saying, everyone wants a program that starts up and then saves a 64-year-old male at a marathon who collapses, right? But that wasn't the patients we were getting. And as I talked to more of my colleagues across the country, similar issues were coming up. And so the goal of this talk is to bring together some expertise and some insight into where we are, and then what our respective roles and future responsibilities are with regards to ECPR implementation. With that said, I'm going to let you guys go ahead and introduce yourselves.
Hi, everybody. I'm Raghu Sithala. I'm an emergency physician and intensivist up in Boston at Mass General Brigham, and I'm the ECMO medical director as well.
Hi, I'm Anna Candela. I'm an emergency medicine physician and intensivist currently at the University of Washington, where I work in the MICU as well as doing ECMO research and with the ECMO team.
Dare I risk 2 microphones? I'm Nicole Bosson. I'm a medical director for the Los Angeles County EMS system, background as an emergency and EMS physician.
So we have a couple questions, and then please feel free to interrupt or raise a hand. We will have some time at the end. Hopefully we have a 20-minute session. So the first question I would say is, what is, from your guys' perspective, the role and importance of early integration and cooperation with EMS when thinking about implementation of ECPR for a hospital or an institution or a community?
Well, I'm highly biased with this one, so I'll jump in. As a background, in Los Angeles County, when we started out with ECPR, it was like many places, right? Just individual tertiary care centers occasionally performing ECPR when a patient happened to show up that met their criteria. And when we engaged with the EMS system, we actually were able to vastly expand access to this therapy. We successfully completed a pilot in September, 60 people cannulated, 27% survival, and we are now integrating ECPR into our regional system of care. But the reason why I think EMS is essential is there are really 3 problems that we've seen with ECPR in terms of the trials and expanding on access, and that is early recognition of these patients really early in their resuscitation, and then time, right? Moving them quickly to the hospital within that window of time to get cannulated, and quality, maintaining the quality of the resuscitation throughout that entire process. And that takes EMS understanding what patients the hospital would consider cannulating, having processes and protocols to actually integrate that into their care and move those patients rapidly to the hospital. And you need parallel processing so that you have the team mobilizing at the same time that EMS is driving in, which takes communication and coordination. And you need alignment in terms of which patients you're going to move, as opposed to EMS's usual approach, which is stay on scene, resuscitate until ROSC. And so what we were able to do with this engagement and collaboration between EMS and the hospitals was together develop the protocol and iteratively improve. So we started small, we grew big. We started imperfect, we're still not perfect, but we're getting better all the time. And now we're actually bringing on more ECPR centers as they see what's happening. Other hospitals want to get involved, and so we're expanding the access little by little.
I think the thing I want to echo, especially from hearing the system in LA, is that Seattle also has a very strong stay and play mentality. And so when Harborview first initiated an ECPR program, that was a huge amount of buy-in that was needed for our system, which ultimately, did end up being paused. But I think that initial buy-in was challenging for sure.
All right. So let's say you have the institutional, the county level, the regional level buy-in to develop an ECPR program. What are some of the pragmatic training opportunities that you found yourself needing to address as you started to implement these programs?
I'll jump in here. As an emergency physician and ECMO medical director, I think one of the things that emergency medicine has embraced part of their training is simulation. And this is a system-based intervention that is ripe for simulation. So once we've made the decision that this patient is an ECPR candidate or we need to do ECPR, we have made the determination that conventional CPR or ACLS is no longer going to work, right? We've said that, the shocking, the defibrillation, the, medications and chest compressions, this is not going to save this patient's life. We need to do ECPR. At that moment, the most important intervention or a thing that we can do is get on ECMO as soon as possible. So time from arrest to pump is the most important metric that we can actually change and modify for this patient's outcome. So in that manner, we need to refine every step from the 911 call to getting on pump to get that metric improved. And the thing I tell, I teach at ECMO at ELSO, which is the ECMO kind of national organization. And I say doing ECMO is not the same thing as doing ECPR. You can, ride a horse from here to here, or you can compete in a rodeo. And many programs, the first thing they want to do is implement an ECPR program. And I tell them, no, that's not what you want to do. You want to do have basic ECMO before you can do an ECPR program. So before we even embarked on ECPR, we had an established ECMO program, over a decade. And the key thing, as Nicole had mentioned, is we had to engage with EMS and really refine that process. So we, before rolling out our program, we did a mock ECPR simulation at one of our outpatient centers from start to finish, where we had a cannulatable dummy suffer from a cardiac arrest, and we emulated the exact process of what would happen when EMS arrived. We had to modify their protocol of how many shocks they do before they pack the patient up and bring them over to our hospital. And along that lines, we're able to figure out simple. First of all, we timed it, and we saw where the big kind of time sucks were, and we're able to do things like, when we do this, we need to have the Lucas machine, brought from here to here. We need to have the ultrasound machine over there. And we were able to simulate this several times and really shave off, 5 minutes. And when we're talking about time from cannulation to being, time from arrest to being on cannulation to being under 60 minutes, but really being under 30 minutes, 5 minutes was a lot.
The next question I have for you all is, again, getting away from the 55, 64-year-old who just collapses, and we heroically save and it makes the news. What do we need to be thoughtful of and consider when implementing these programs in terms of what populations do we consider, target and expand, or include and exclude?
Yeah, I think I can talk a little bit about both that and sort of what we see after cannulation, which is that, once cannulated, these patients become peripherally cannulated VA ECMO patients. So the ECPR patient then becomes a physiologically quite complex patient, even for the ICU. You're managing dual circulations of the native lung and the membrane lung over the 24 to 48 hours following arrest. Ideally, you're dealing with a recovering myocardium. At the same time, lungs are at risk for developing injury from whatever conventional CPR or etiology of arrest they did have. And they're also post-arrest patients. So neurologically, you're trying to appropriately target your hypothermia, which is actually easier with ECMO, but then avoiding both acidemia, alkalemia, hypoxemia, all of which, again, is harder to monitor and manage in these patients. So cognitively, they're a really heavy load on your ICU. And, thinking of the title of the panel, we need a win. Well, what's a win to your ICU team? The majority of admissions to adult ICUs do survive. And you're looking at, even in a successful ECPR program, talking about outcomes of 30% survival, that means these ICU teams are dealing with these really heavy patients that for every one that makes it to hospital discharge, 2 are going to die. And they're usually, again, these younger patients who are previously healthy. So in our program, we ended up shifting to targeting initially and now these sort of 3 most best outcomes of VA ECMO, or really ECPR. So massive PE, toxic overdose, and hypothermia are all indications for which these patients are still super sick, but have a higher likelihood of surviving to discharge. And then you have the opportunity to celebrate those wins, like we did. One of our hypothermic ECMO patients was actually in the New York Times, and that can kind of build morale and support in your hospital for these otherwise, again, really intense patients to care for.
Yeah, so we similarly had to kind of figure out where was the sweet spot, right? So we started out very broad. We allow 15 to 75 years, so that's one of the largest age criterias. And not only did we start out with refractory VFVT, but we also allowed judgment. So if an ECPR center or paramedic recognized a patient that they thought might get cannulated, they could, on judgment, transport that patient to the ECPR center, mainly because it was also the closest cardiac arrest center. But what we found through the course of our pilot, we had about 250 patients routed, was that the people that were getting on pump and surviving were either our refractory VF patients or massive PE patients. And these judgment patients, we really couldn't find another population that was rapidly benefiting. I think we didn't have the numbers. We didn't have a lot of overdoses that got into our population, but maybe they would do okay as well. So we learned iteratively who the patients were that, and our paramedics could recognize them. The other thing I'll say is that we've actually seen a benefit beyond the small number of patients I'm talking about, right? We're 8,000 cardiac arrests a year in LA County, so 250 patients, right? That doesn't sound good. People are like, well, that's not very many patients, right? We saved 15 people, but we saved 15 young people who mostly went home, and that is a win. But we also found that actually when we implemented ECPR programs, the paramedic units that were participating in the pilot had better overall cardiac arrest outcomes compared to the rest of the system. And we think that's likely because that they were focused on good quality CPR, that they had hope that these patients could survive and a therapy to offer. And so, that focus on, again, that quality and the integration with the healthcare system, I think is another benefit that can extend beyond these small number of patients. And that's another win that we can share with our system stakeholders.
I'm just going to add to that. And in order to have wins, as an ECMO medical director, one of the hardest things that we have to do is tell consultants, tell primary teams why this patient is not an ECMO candidate. Because, oftentimes, the team that's looking at these patients they have exhausted all conventional medical therapies and they call for ECMO. But again, we're not trying to, keep bodies' blood circulating. We're trying to take patients home and bring them back to their families. And how we go about having a successful ECPR program is really picking the right patients in order to have successful outcomes. And that goes back to what Nicole was saying, is that I think by and large, it's refractory VF, it's massive PE where you've either already diagnosed it or the patient came off a flight, was on OCPs, had a swollen leg, syncopized, and then told you that pleuritic chest pain, and then arrested. And then potentially toxicology situations, because when a toxicologic patient arrests, they're usually very, very far gone. But if you're in that scenario where you're evaluating them prior to their arrest and they arrest, that might be a scenario where we can have a win. And then hypothermia as well.
All right, so we have about 5 minutes left. I just wanted to open it up if there's any comments or questions regarding implementation. Okay. You can project. Okay.
Patient selection, because it's so difficult at times. Excluding hypothermia, cardiotoxic medications, and massive EP. If you're called to other PEA rhythms, are there any biomarkers? Are you just flat excluding them if they're a lactate you're using?
In fact, I think I want to say at Hennepin they had lactate and then removed it, and I know it's not part of ours.
Yeah, lactate in particular, it would be really nice if we had a 18 or like a science or an evidence-based cutoff of 16, 10, a pH of 7. I think the really frustrating thing is we've seen patients at our institution with a pH of 7.2 and a lactic acid of 8 have a terrible, terrible outcome and not survive more than 8 hours on pump. And then similarly, someone that you cannulate with a pH less than 7 and a lactic acid of 19 come off in 5 days. And so I think precision medicine biomarkers are an evolving field in this. I don't think we're there yet, and I think that relying too heavily on these hard cutoffs can really frustrate not necessarily the ECPR physician team, but if you have unfortunately a 17-year-old, it becomes this 17, 18-year-old young, really tragic case. It becomes really difficult to say, 17 we can cannulate, 18 for a lactic acid we can't.
It causes delays too. Our hospitals, we had to start it out with this idea of the MRC kind of criteria, the lactate, the CO2, and then everyone abandoned it individually, actually recognized it was just causing delays and it wasn't necessarily discriminating. And so they're just, we're bringing them in, we agree on the criteria, and they're cannulating unless they learn something about, downtime and other factors that we didn't know about.
And the way I think about PEA is, you just mentioned the 3 reversible causes, and if it's not those 3, then it either is a irreversible cause or it was a VF arrest that you didn't get to in time. It degenerated to PEA, and that's going to be hard to come back from.
So I should be able to talk loud enough. So my question really is that I'm skeptical, have been since it started, because I think that very few EMS systems in the country function at the level of Seattle.
We won't be offended.
You can't argue the facts, just everything that they're able to do. We're still missing the point. We're putting everything on the back end. We don't have the level of bystander CPR, AED deployment, access, and I think a system you need to have that cleaned up before you can decide who's going to enter an ECMO program. And if you don't do that, if you spend all the money in the back end, you're not going to have the wins, or they'll be very few and far between. And I still think we're not putting the effort to save people where it needs to be done. Because the best case to come to as a paramedic is you arrive on scene and they already use the AED and the person's talking to you. That's the person that really goes home without a question. So.
I 100% agree. To echo the AHA, the chain of survival, right? It's the chain of survival for a reason. So the most important factors in a cardiac arrest are good quality compressions and time to shock. I think what's frustrating now is there are situations where we have that, and we do have refractory VFib. And so what options do we have to explore especially from a research standpoint, because the evidence, as you suggested, it's not clear on whether or not ECPR will outperform comprehensive BLS and ACLS. What I will say is pragmatically, and there's some more expertise here, the institutional buy-in to ECPR and the expertise, if you have it, it's not necessarily a drain on the system. In fact, it's viewed as an asset. And so if you can safely and consistently cannulate the appropriate patients, then you are not detracting from ACLS or BLS. You're merely adding another link.
Yeah, and my take on that is it's not one or the other, right? It is 100% agree with you. That is actually the most primary important intervention. But after 3 shocks, 30 minutes, or whatever marker, there seems to be a precipitous decline in survival. So I think ECPR's role is for those patients that meet whatever that metric is. And we're still trying to define that. Is it 3 shocks? Is it 4 shocks? Is it 30 minutes? Is it 25 minutes? Is it 45 minutes? And once you've made that decision that conventional CPR ACLS has not brought the patient back, what's the next therapy we can add? And I think refining ECLS is the therapy that we can add.
Yeah, and to your point about, these teams that become trained in this model do not deliver worse conventional CPR, in fact, better. And so, and again, this is speaking to your model rather than ours, which now, again, has a very restrictive protocol for ECPR.
Yeah, I'm so happy you made that point because that is huge, right? Ultimately, we will actually have more patients who could benefit from ECPR if we perfect the system, because a lot of our patients aren't getting cannulated because they didn't get bystander CPR, they weren't witnessed, they didn't get these additional things. And so they actually become non-candidates because what we're trying to save is their brain, and the brain is already lost. So if we can really perfect that system, and in Los Angeles County, obviously we're focused on each of these steps, the ECPR just becomes that one additional therapy for the patients that, despite all these other things lining up, they still didn't. They just didn't get ROSC.
So I'm interested in how you balance kind of the nuances of stay and play versus go in protocol system, where you're not typically asking your paramedics to sort of a lot of judgment, in the moment. And this is very difficult to judge. I think probably, and the earlier you get to this, the more difficult it is to judge the summer because you have less information. So I just love to hear about and how you switch, turn the switch from stay and play to kind of like, all right, play but just enough, and then get into the hospital. So love to hear about like,
Yeah. That has been a huge focus, was how do we decrease scene time, because that time to cannulation being huge. It's empowering the paramedics, right? You can't talk about it, you've just got to do it. That's what we learned. So it was shock, still fibrillating, start to package and go. Now we expect them to shock a few more times en route, and actually a huge number of patients didn't get cannulated because they got ROSC, and they actually did really well if they got ROSC. So one of the things we absolutely mandated was a mechanical CPR device. And I understand the data on those, hasn't shown a benefit. But when you're putting the patient in the back of an ambulance, you've got 2 problems. You got the safety of your paramedics, and you've got the quality of the resuscitation that declines. So they absolutely had to have a mechanical compression device. They absolutely had to train on it regularly to ensure, and regular training on those devices has been shown to be beneficial. So that they, as the paramedics, can recognize this patient's not responding to my conventional therapy. I have them on a mechanical compression device. I've already managed the airway. There's nothing else I need to do on scene. I'm going to move to the hospital because there's a therapy that this patient could potentially benefit at the hospital. If there's no therapy that the patient can benefit from at the hospital, then I'm going to stay, continue to resuscitate until ROSC. And we've managed to balance that pretty well. Did we have a few patients that the paramedics just didn't recognize? Yes, but actually it was very few. The paramedics were excited and engaged in this idea that the patient could actually have they could have an alternative option for these patients that generally, they feel are salvageable, but they can't do anything more. They keep shocking and the patient's not responding. So that's just ongoing engagement of your paramedics and really making them the decision makers to move to the hospital.
Small cohort of paramedics or rigs that actually get moving in. Why is the LA County CPR?
No, we have 400 ALS units. We have 4,000 paramedics and 400 ALS units. We did start with about 40% of our system, but now all of our paramedics are being trained currently. We launch our regional system in July 1st, and all of them, save one department that I'm working with, have mechanical compression devices on all of their ALS units.
This is a great panel, great discussion. Can you talk a little bit about who is doing cannulation and where and cannulation is occurring?
I can briefly talk. I think it's probably different for everyone. I can say that at Harborview, which is a county hospital and a level 1 trauma center, the ECMO consult team is comprised entirely of EM critical care doctors and trauma surgeons that alternate call. And when again these very specific patients come up. Oftentimes they're in house, and if they're not in house, they will drive in immediately. That does, mean that we aren't usually able to get access fairly quickly, but that is a huge problem, right? Is having cannulators on site 24/7. And I will say that it sounds like, and I'll hear more from my colleagues, but many programs start by thinking you can second staff somebody who's already in house to be the on-call cannulator, and that can become really challenging, as it did for our trauma surgeons, as it does sometimes for our EM critical care docs on shift or in the MICU.
Yeah, my response is whoever can safely and consistently obtain common femoral access is who's cannulating under ultrasound guidance. At our institution, that's a combination of cardiac surgery, interventional radiology, and emergency medicine. And so it's a small team that does it. And there's some politics with the cannulation and who's going to generate the RVUs from those cannulations. However, I tend to focus on who's safe and consistent, and there's a large number of specialties that can do that.
I think it's going to be really important.
Currently we're doing emergency department and then on the floor. So in hospital and out of hospital cardiac arrest occurring in the emergency department. I think we can rapid fire. So cannulations do not occur in the cath lab at Yale.
So I think the most important thing, again, I mentioned earlier, is time to getting on pump. So it's going to be unique to your institution. Who's there 24/7? Who can do it fastest? Intervention, the answers range from emergency physician, intervention cardiology, trauma surgery, cardiac intensivist, cardiac surgery. At my institution, it's a mix of the cardiac intensivist and cardiac surgery. And the cardiac intensivist can be from any specialty: anesthesia, emergency medicine, cardiology, pulmonary.
And I apologize, there is another speaker starting in 2 minutes. So if we want to rapid fire our who's cannulating answer.
You have 5.
Sure.
Yeah,
It does vary, but cardiac surgery and interventional cardiology are the main ones. We also have a hospital coming up that's going to be doing it with trauma surgeons to cannulate, and so in collaboration. And most of our hospitals are doing it in the ED, but ED physicians are not currently cannulating. And one hospital is doing it in the cath lab. One hospital actually was doing it in the cath lab and found that moving it to the ED actually saved them time, and so they changed their process.
Yeah, if you have a ECMO cart, a bunch of tables, and an ultrasound machine, you can cannulate at the bedside. So.
And similarly, we found that cannulations in the ED, believe it or not, tend to be the most calm environment and the most comprehensive in terms of resources and backup.
And I'm just going to put a plug in for my ultrasound friends. TEE in the ED is very helpful for achieving ED cannulations.
Yeah, especially for positioning. Yeah.
Thank you all for coming at 8 a.m. And thank you to our panelists.
Yeah, we just.
Yeah,